So most men with prostate cancer, the disease doesn't spread, but in some it does. And there are some quite classical ways that it spreads. This is a bone scan, and the hotspots, so-called hotspots here, you can see as black areas, and you can see where it's distributed in the ribs, pelvis, long bones, and the vertebral column just here. We used to think that was because of venous plexuses, but actually it's much more to do with the growth factors that are found in those locations. So a man with persistent bone pain with prostate cancer is a worry that there'll be bony metastasis. This is a CT scan, although the most common modality for imaging prostate cancer is an MRI scan, but it just serves as a reminder that you can get local invasion of the disease out of the side of the prostate. Here's the prostate here in the centre, and you can also get lymph node involvement as well, another important form of spread. So in terms of the bone spread, these are the places it goes to. The important thing is it's sclerotic. Most or a lot of bone secondary cancers punch out areas of bone, but prostate cancer causes quite a fluid reaction and the bone tends to be more dense. Occasionally it can go to these other locations, but it's far from typical. So in summary, prognosis is proportional to stage and grade. In other words, how far the disease has spread and how nasty it was in the first place. So what do we do when we have a patient we think has prostate cancer? Right at the start, we take a full history and examination. And one of the particular things we're thinking about is, what's the patient's comorbidity like? Have they got a good chance of living 10 years or more? Very important thing. Even though rectal examinations are not favoured by either patients or doctors, they are very important. We need to know if the patient has palpable disease, very important thing. And a number of special investigations will be considered, most important of which are PSA, MSU, once they go to the hospital, usually a transrectal ultrasound and biopsy, or maybe a perineal biopsy, possibly beyond the scope of this to discuss that too much further. And if the patient has symptoms as well, we'd consider a flow rate and a post-nutrition scan. So there are three things that can put up PSA, prostate-specific antigen, broadly. Prostate cancer, just having a large prostate and any kind of inflammation in the prostate. Any of those three will do it. So just in terms of other things that might impact upon it, rectal examination, unless it's incredibly thorough, more of a prostatic massage is not going to increase the PSA. Cycling to work, well, definitely mountain biking, pretty vigorous at that to have any impact. Infection certainly will have an impact. And ejaculation in the last 24 or 48 hours will also have an impact too, as with any kind of instrumentation of the urinary tract. There are some medicines which affect PSA, most important of which are 5-alpha reductase inhibitors, and they'll usually halve the level of PSA by shrinking the gland. So as I said, the thing the patient will have when they come to the hospital is a transrectal ultrasound and biopsy of the prostate. And you can see here from this drawing that a probe is passed into the back passage, and then a number of biopsies are taken, often 10 or 12, with 4 or 5 cores from each side. There are other types of biopsy, perineal, but this is still the commonest. And the major drawback with it is infection and bleeding. These are the sorts of features that you see. And if I just get the arrow up, there's the prostate here, and there is the bladder there. The changes in the prostate are often quite non-specific, so it's very difficult to be didactic about whether there's disease or not. And really we use the transrectal ultrasound simply as a way of making sure that we've got relatively even biopsies taken from within the prostate. So what are the approaches we can take with a patient? The most conservative is active surveillance, active monitoring. So in this situation, we have a diagnosis, the patient has prostate cancer, and maybe their PSA is very low, they're young, they don't want to have any side effects, so they may just undergo a period of monitoring. These aren't the sort of patients who we discharge to the community, they'd be followed up at the hospital. The next set of options are radical, some sort of curative treatment, be it surgery, radiotherapy or other new modalities. And then patients that aren't fit for those, they may have palliative care, or they may just have what's called watchful waiting, so we keep an eye on them and make sure they don't come to harm. Why do we take that kind of approach? Here's some data, which is a synthesis of other people's outcomes on prostate cancer, and it is a cross-section of the natural history of screening detected prostate cancer. So if we went and screened people, what would be the effect of radical treatment on whether they'd survive or not? So if we take a typical patient with Gleason 7 disease, so that's right in the middle, we take a man who's 55 to 59, and we look down here at the chance of altering what happened to them. At best, you've got a 12 out of 100 men will have a survival advantage, maybe as low as 5 in this other data. If you take a 60 to 65-year-old, we've got 9 in the Albertson data, 4 men out of 100 in the SWEET data. And if we look at 70-74, we drop right down to 3 and 2. So in that way you can see that you do need to have a decent life expectancy. Clearly as the grading stage worsens, as the grade worsens, so here we have Gleason 7, you've still got a higher chance here than if you're right at the bottom. And that's the same throughout all the age groups. And here's another way of looking at it, Parton's tables. So here you have a man, let's choose a chap here with Gleason 7 disease, and let's say that he is 55 to 59. This got two areas here. We've got a dark grey and a light grey area. The dark grey is the chance of the man dying from prostate cancer, and the light grey, sorry, fighting my mouse, light grey is the chance of dying from a disease other than prostate cancer. And you can see here at, it's gone again, at a youngest age at year 0, 100% of men are still alive, and as time goes by, some men die of not prostate cancer and some die of prostate cancer. And as you come down the scale of Gleason, you can see that you're much more likely to die of something else, and as you come up, it becomes ever more likely that you die of prostate cancer. But it does really depend on the age that you present. So if you're young and you've got nasty disease, you're going to do worse. If you're older and you've got well-behaved disease, you're going to do a lot better. It's common sense really, but it's interesting to see it laid out in this way. So with any of the treatments that we give for prostate cancer, if we look at the anatomy, we can work out what the complications are likely to be. We may damage the bladder, we may damage the nerves to erections, we may damage the continence mechanism, we may damage the rectum, and those are indeed the common complications. So all of them, radical prostatectomy in particular, can damage potency. It depends on the technique used and whether there's nerve sparing. But if you don't use nerve sparing, then up to 90% of men will be impotent after surgery. They'll benefit from the use of tablets or vacuum tumescence devices, but they will have difficulties. Continence can also be an issue. Many men will be wet immediately after surgery, and a large number will be wearing pads at 3 or 4 months, at least for security reasons. By a year, most surgeons will have 99 out of 100 men dry. Where the bladder is joined onto the urethra, there's also the chance of stricture at that point and blockage, and that can be a problem, causing slow flow further down the line. And of course, it's an operation. There is a risk of death, albeit small. The other possibility is that the disease has either got to the margins or spread and it's not been measured, but that is the same for all the different treatment types. Within radiotherapy, there are a number of different ways of giving it. Here's a bit of standard planning for radiotherapy, and the easiest form is you shine radiotherapy in from 3 different angles into the patient's prostate. So if it's shone in, here's the patient shone in from here and here and from the front, we could work out an area where most of the radiation is going to go. One of the drawbacks of radiotherapy is that it's about 7.5 weeks of treatment, and it's a daily treatment Monday to Friday. Most people have tolerate it very well. About half will develop problems with impotence. Incontinence is unusual. Stricture is possible. People don't die from it, but it certainly can fail. Brachytherapy is an alternative technique, and there are 2 versions of this, but the commonest is this so-called low-dose brachytherapy, where a large number of seeds are placed within the prostate, and they give out radiotherapy over a course of time and treat the prostate. And here you can see the seeds within a man's prostate. Again, the impotence rates are supposed to be better, so 25% or so. Incontinence is unusual, but men certainly can have urinary symptoms, as they can with all forms of radiotherapy. Stricture can occur. Again, death and failure are unusual. So how well do these patients get on? Well, here's a sort of landmark study from some time ago now, but the figures are still relevant. Nearly 3,000 patients with standard prostate cancer, over the course of a nearly 10-year process. Some of them had radiotherapy at a lower dose of radiation, some had a higher dose, and some had combined treatment with brachytherapy and top-up radiotherapy. They're usually the worst patients. And there was quite good levels of follow-up. How do we know if the patients had ongoing disease? Well, if they had a PSA of 0.2 with a radical prostatectomy, that was a sign of recurrence disease, a measurable PSA, or if they failed the so-called ASTRO criteria, which is 3 PSA rises in a row. That was the indication for radiotherapy failure. And you can see here that of the radical prostatectomy men, 81% were still alive with disease-free survival at 5 years. For the higher dose of radiotherapy, again 81%, brachytherapy 83%, and combined 77%. And that's probably due to a skewing of the type of patients that were put into that arm. So in summary, there are multiple options. We always need to consider life expectancy. We need to always tailor the treatment to the patient and their fears and worries about side effects and what's important for them. We should try not to do any harm because that's an easy thing to do. Next section is what if cure fails, and I'm going to put that in a separate video.